Hey gang, good morning. Welcome to PTA 105. I think that I have my microphone figured out so it won't be fuzzy, but please let me know if this quality is not good. Just shoot me a message or something. And I'm also going to be uploading lectures to a YouTube channel for you guys so you can maybe listen a little more mobily, okay? So let's check out goniometry. This lecture follows chapters 1 and 2 of Clarkson, which is your required reading, and it also follows the goniometry lecture handout, which is in the module that's for you to download. Hopefully you guys have kind of looked a little bit at your goniometers you got in last lab weekend in 202. If for some reason you did not get a goniometer, please let me know. But I think that everyone is taken care of. Alright, so when you get to your first lab for goniometry, we are going to be doing a little brief introduction. I'll probably go over some of the same material that's in this lecture. Incidentally, a lot of what's going to be on your goniometry quiz will be from the required reading and this lecture. So we'll talk about that a little bit in lab. And then we're going to be looking at how we actually do goniometry. We're going to start with the upper extremity, and we'll move to the lower extremity, and then go over spine goniometry. And you guys each will have a assigned joint to measure. You can look through the module to figure out the assignment, and you'll be presenting that in lab to your fellow lab partners, and you'll be then doing a little self-assessment of your presentation as well. So anyway, why do we do goniometry anyway? Goniometry is something that I use every single day in the clinic. We talked about how we need to have something measurable in each note with our documentation, and goniometry is a really easy go-to. So just some definitions here with joint range of motion. Okay, so by definition, active range of motion is the movement of a segment within the unrestricted or whatever's available range of motion, and it's produced by active contraction of the muscles, all the muscles that cross that joint. Okay, so essentially the patient is performing the motion. Now, we can measure all of these with goniometry. Okay, active assisted range of motion is, by definition, it is a type of active range of motion, so it's active assisted. That means the PTA or the PT, the therapist, or even another outside force like a pulley provides assistance to whatever the prime mover muscles are, and then that completes the motion. So active assisted. And we're going to be building on these terms as we get through other courses. These will come up again in your therapeutic exercise course next summer. And now passive range of motion here is entirely passive, just like it sounds. So PROM, by definition, is the movement of a segment within whatever's available range that's produced entirely by an external force. Usually that external force is the therapist. So there is little to no, hopefully, voluntary muscle contraction. Okay? So the patient is not providing any assistance with their muscles. You as the PTA are just moving the limb through its available range of motion passively. Okay? And then end feel. We briefly talked about this in kinesiology lab, but end feel is a sensation or what you feel at the very, very end of passive range of motion. Now, you know that you're thinking about what might be causing the feel. The muscle tissue stretching, the joint capsule stretching, maybe there's some edema in there. So it reflects the tissues or structures that limit the joint motion. So what's limiting or what's causing the end feel, either physiological or pathological. So we talked about end feels last quarter being what's normal for end feels, and then this quarter we're going to start building on what's like an abnormal end feel. Okay, and if you look in your handout, you will see that normal infills are soft. That comes from like soft tissue approximation. Firm is a normal infill. That can either be a muscle stretch, a capsular stretch, or a ligament stretching. And a hard infill is a normal infill. That's when bone contacts bone. But abnormal infills, a soft infill is sometimes considered abnormal if it feels boggy. Say there's a lot of edema in the joint. A firm infill, if it's there but it shouldn't be, this would be like an abnormal muscular capsular or ligamentous shortening. A lot of times shoulders feel this way. If that posterior capsule is abnormally short, they'll get to the end of internal rotation range of motion, and it will just stop with a firm end feel. A hard end feel, when it's abnormal, when say like an elbow extension, the olecranon goes into the olecranon fossa, and that is a hard end feel. That's a normal end feel for elbow extension. But what happens if you get a hard end feel in, say, elbow flexion? That should be a soft end feel where the forearm tissue touches so like the distal forearm touches the proximal forearm, running into that bicep muscle belly. That's a normal soft tissue approximation. But then what if it abruptly stopped? A hard end feel would be considered abnormal if it was felt in elbow flexion. Okay, and an empty end feel, again, I'm referencing your handout here. An empty end feel is when the patient expresses subjective pain level that is before the end of their passive range of motion, and that can indicate if there is maybe a tumor or bursitis or any like tear in the cartilage. So empty end feel is when you cannot effectively assess the end feel in its reality because the patient is expressing pain. Sometimes you'll see an empty end feel with a fracture. Okay, and then your notes list a springy block. This one is not too common, but once in a while you'll get a springy block, like with a meniscus injury. That's where you press down, try and assess the range of motion, assess the end feel, and there's a rebound. You can either see it or feel it. And a spasm is when there's a hard, sudden stop to movement, and sometimes, usually actually, this is accompanied by pain. A spasm is most often seen when it's with pain. It's like a muscle spasming, but without pain it might indicate if there's a central nervous system lesion, and we'll talk a little bit more about that when we get to our sensory portion of the class. So when do we absolutely not perform goniometric measurements? Okay, absolute contraindications. So anytime when moving the segment of the joint could disrupt the healing process, like in a fracture or in a surgical repair. So if rotator cuff repair, for example, I'll just use that, the protocol is to not have any active range of motion performed for at least 12 weeks, because otherwise there will be too much stress and strain on the repaired supraspinatus tendon. And so they tell you to not do any active range of motion with the patient. So by default then you are not going to measure any active range of motion. Okay, and fractures the same way. Anytime moving the segment will disrupt the healing process, you're not going to measure. If there happens to be a subluxation or a dislocation or a fracture, essentially if the joint is hypermobile, you can use caution and measure. So a hypermobile joint may be measured, that's precaution, but it's an absolute contraindication if the joint is dislocated, the bones are fractured, or the joint is subluxed. Myositis ossificans is a disease that includes little bony calcifications inside the muscle joint. That is a contraindication to measure. So do not perform goniometry if your patient has myositis ossificans. And I mentioned that if there is a post-surgical fusion or fixation of a joint, so rotator cuff repair is one example I gave. Another one I can think of is like a lumbar fusion or a cervical fusion. Often they will give a restriction of no BLT, no bending, lifting, or twisting. So you would not be performing any lumbar flexion range of motion, because that would be bending, any rotation range of motion, because that would be twisting. And then another one too is if, like with the total hip, there are posterior total hip, they absolutely may not flex their hip beyond 90 degrees, internally rotate, or adduct their hip. So if there is a fixation of the joint, you will not be measuring as well. So basically you just follow the protocol, and you guys are going to be learning all these in your Therex class. I'm just giving some examples here. You follow the protocol and you do what the surgeon tells you, okay? Now, goniometry is precautionary. I mentioned the fourth one down on the list there. I mentioned the hypermobility is a precaution for goniometry. You just, excuse me, use your head. Don't use also that when assessing the end-field too. And just use precaution. And if there's moderate or severe pain when the patient is moving their joint, you can just like go slowly, use take any supportive measures you need by giving them good joint support, hand placement, that kind of thing, so you can get through the range of motion, but know that it's precautionary for goniometry. If the joint is inflamed, also you may want to hold on measuring. So for example, with a ankle sprain, you might decide to, if they're very acute, you might decide to not measure. So an inversion ankle sprain, inversion and plantar flexion are going to be very painful, so you may use your best judgment and not choose to measure both of those motions on, say, their first or second visit while they're very acute. And then of course you would document, in the subjective you would say patient experiences pain with inversion and plantar flexion, or reports pain with these motions, and then in objective you would say inversion and plantar flexion are not measured today due to patient's subjective reports of pain. Okay. If the patient has osteoporosis, or if they have just a recently healed fracture, anytime you think that the bone might be brittle or weak, you will want to use caution. And let's jump down to if they're in the acute stage of a soft tissue injury, the ankle inversion sprain is a perfect example there. And also too, if they've been immobilized for a long time, you are going to find most likely that they're fairly stiff. So you will be wanting to measure their joint range of motion, but you're going to go slowly and use care if it's painful. Okay? So, excuse me, I don't know what's going on with my throat today. Anyway, so you've been looking at your goniometer, and I know some of you guys are already familiar with these since you have been aides or whatever, but those of you guys who are brand new to this, just know that there's different types of goniometers. I am showing you a picture here of a universal goniometer, and then this is also a universal goniometer, but it's a 180 degree goniometer. And then some tape, sometimes you'll use a tape measure to measure joint range of motion. The trunk is a perfect example. So we measure lumbar range of motion lots of times with a tape measure, and I'll be showing you guys how to do all of that, and Claudia will be showing you guys in Pierce. So there is one arm on the goniometer that stays stationary, okay? And there's one arm on the goniometer that moves. So what you're going to do always is you're going to place the axis, or the center of the joint of the goniometer, right on the joint. And if you look at the charts that I have, quite a few different places in the module to look at, you can see for each joint what the axis is. Okay, and you'll place your center of the goniometer right over there, that spot, and then you will place the stationary arm pointing towards one bony landmark that you know how to palpate very well from kinesiology. And then you're going to place the movable arm pointing towards the other bony landmark, okay? And you'll then keep the stationary arm still on that bony landmark, keep the axis right over the center of the joint, and then move the movable arm, okay? Now there are, this one's 360 degrees, this one's 180 degrees. You're going to keep in mind that you'll want to use an appropriately sized goniometer for whatever size joint you're working on. So a smaller joint like an MCP joint or an MTP joint, even some of the the wrist carpals will want to use a smaller goniometer, okay? And a bigger goniometer for hips and shoulders and that kind of stuff. So one word of advice here, do not be intimidated by the sheer amount of numbers you see on this dial, okay? You are just measuring an angle, all right? So it's a great idea to memorize the average ranges for each joint from those charts that I have for you. Memorize what the average ranges are so that when you use the goniometer and read it, you will know, oh yeah, that's right, shoulder flexion, I remember 175, 180 degrees, boom. I know that. So I'm looking at the number here and I know that it can't be, 240 degrees on this side of the dial. It has got to be the number that I know is closer to the average range of motion for that joint, okay? You're just measuring an angle. Don't be confused by the sheer amount of numbers on the dial. So goniometry is considered both valid and reliable. By definition, validity is the degree to which the goniometer measures what it's supposed to. So is essentially the angle produced between bony landmarks, is that a valid measurement? Yes, if you are always placing the stationary arm and the movable arm on the exact same bony landmark. Now, you are going to see different ways to measure joints in clinic versus what we teach you in lab. Now, what we teach you in lab is the standard, okay? And it is valid when you're using the same standard. Now, I will tell you straight up, there are ways that I measure in the clinic that are faster and quicker, and I don't follow what is listed in Clarkson all the time in the clinic. However, to learn, and as you guys are first starting, I need to have you always go with the pictures and the examples that are laid out in Clarkson. So also, a little word of caution, don't Google or YouTube how to measure for your project here. You're going to only follow the example in Clarkson, and please only show that way, because I have to make sure that students know the textbook way to do it, and then you can learn if there's a clinical way that the PT that you're working for likes to measure it. Of course, you're going to measure it that way when you get out in the clinic, but for right now you are only showing and learning the Clarkson examples, okay, because that is what is valid. There's a couple of studies they have done on the knee and the elbow, and if anybody is interested, I can get you those links. Thank you, by the way, for your great work on your 101 evidence-based practice projects. So I enjoyed reading those, and I will gladly give you the evidence-based articles on goniometry if you would like them. So it's considered valid just like an x-ray or photographs when it is used at the beginning of therapy, and we use goniometry at the beginning of therapy to help establish treatment goals. We take pre and post-op measurements, you saw that in your documentation master sheet, to measure how effective the treatment is, okay? And then at the conclusion, at their last visit, we're going to take range of motion measurements to help document the overall treatment progress and the effectiveness, okay? So that's validity. Now, reliability, by definition, is the degree to which the goniometer yields the same measurement repeatedly from the same operator or different operators. So Essentially, reliability means that a measurement is consistent, repeatable, and reproducible. So, to increase reliability and to reduce the amount of error when you're taking a range of motion measurement, it is ideal to have the same therapist measuring at all times. So how do we maximize the reliability? We always standardize using the same measuring device. Ideally, number 4 here is to have the same examiner measuring. And we standardize. This is why I am kind of hammering out the idea to only use the setup that's listed in Clarkson. We standardize the reliability, or maximize the reliability, by standardizing the position we measure in and the bony landmarks that we use. And the procedure, we want to try to have the measurement done in the same way for each time. So for instance, if you measure shoulder flexion in supine, which is the way that it's listed in Clarkson, the next time you will want to measure it in supine again. Okay, don't measure it in standing. We also want to try to have goniometry done in the same time during the treatment, same time each day, because you may find that somebody is a little stiffer in the morning compared to the afternoon. Okay, and you hopefully in the treatment, like, you want to be consistent in the treatment time too, not only time of day, but like hopefully at the end of treatment your treatment has increased the range of motion. So say ideally you're measuring a pre-treatment range of motion and a post-treatment range of motion, and you're doing those at about the same time during the treatment. Okay, so they have taken some more in some of those studies I referenced. They talk about this idea of intra-rater reliability versus inter-rater reliability. So studies show that intra-rater reliability tends to be higher than inter-rater reliability. And what this means is, if I measure and I'm always that same person measuring, then that is more reliable than, say, if I measure and then my coworker measures. So they have found that there's as much as a 5-degree difference between person to person, therapist to therapist measuring, even when we use the standardized position, procedure, and bony landmarks. Okay, so there's plus or minus 5 degrees is considered an accurate measurement. If, say, we're doing a skill check, you measure shoulder flexion at 170, and you're spot on your landmarks, spot on your positioning, spot on your procedure, I could come and check you, and I could actually get 165 degrees, minus 5 degrees, or I could get 175 degrees, plus 5 degrees. That would still be considered an accurate measurement. Okay, so that's why it's best to be always the same person measuring if you can, because intra-rater reliability is higher than inter-rater reliability. So I think I mentioned both of these, or all of these already. You measure joint range of motion at the beginning of therapy when at their initial evaluation. Usually that's the PT that's doing that to help establish treatment goals. Pre and post treatment measures to document how effective or non-effective the treatment is, and hopefully it's on the effective side, or else you might need to think about what you're doing. And then at their last visit to document their overall progress and the outcomes of therapy. Okay. And then, so just a couple of examples of how to document. It always goes in the objective. Okay. Now, one mention here, shoulder elevation is sometimes used instead of shoulder flexion. Okay. And you will sometimes see 0 to 180 degrees listed as the whole range, saying going from neutral, arm at your side, to 180 degrees over your head into flexion. Sometimes they'll call that shoulder elevation in a range like this. And another kind of weird outlier in measuring is knee extension and also elbow. So knee range of motion, and elbow range of motion. These are two little weird outliers that you're going to want to make sure to know how your place of employment likes to measure them. And they're both okay. All right, so you say somebody is lacking knee extension. So this is looking like a number line here. So we've got 0 degrees would be normal for knee extension. Say they're lacking knee extension, they can't quite get all the way down to 0, and they can flex their knee to 135 degrees. This would mean lacking knee extension, like on a number line here. If full extension was 0, they're lacking 10 degrees, can get to 135 degrees. Okay. So then if you can also, though, not to totally confuse you, sometimes you'll just won't see this 0. Sometimes people leave that out. So you could also read that then as lacking 10 degrees extension to 135 degrees flexion. So sometimes they leave this 0 off. Again, both knee range of motion and elbow range of motion. Okay? Where it gets a little confusing, though, is what if the knee is hypermobile and they can go beyond 0, okay? So the number line there would be, okay, 5 degrees of hyperextension, right? It's 0 is normal for extension and 135 degrees flexion, but you see then that would be kind of confusing. That you can't just like take that 5 off, right? So I am okay with either way of documenting it. I personally feel like this number line is pretty easy to follow. It makes sense to me. If 0's full extension, they can't quite get to full extension, they're lacking knee extension, okay, and to 135 degrees flexion. I will try to explain this and show you this a little bit more in lab too, and I'll make sure Claudia goes over this as well. And anytime you measure goniometry, if you do happen to measure in a different position that varies from what's shown in Clarkson, say if the patient has a condition like spinal stenosis where they are uncomfortable lying prone, you may not choose to measure hip extension in prone that day because of pain, okay, or back pain. So you would then just note that anytime you do measure, if it is varied from the standard position, okay? So here's what this looks like. This gal is measuring shoulder, looks like she's going to measure shoulder abduction. This is measuring wrist flexion. You see she's using a larger goniometer here for a larger joint and a smaller goni for the smaller joint. So here's some basics. You always want to make sure the patient is well supported and comfortable. Use whatever pillows you need to. I will actually take points off if the patient is not in a good, supportive, comfortable position for you on your skills checks, okay? Also because it's important to use pillows and bolsters, and you'll see in Clarkson how to exactly position and whatnot, because that actually puts your joint in the best position to be measured too. Usually, like for shoulder external rotation, I'm thinking just example, you always use a little rolled up towel underneath their humerus, because then that puts the axis, which is the olecranon, at a better position for you to measure, okay? Ideally, you have the joint in its anatomical position, okay? Anytime that you need to stabilize, you want to stabilize at the proximal joint segment so that you restrict any substitute motions, okay? And then you want to make sure that they're positioned well so that you can actually move the joint through its full available unrestricted range of motion. Again, I highly suggest you commit to memory the ranges for each joint, okay? And then you position them again in a way that the goniometer can be placed properly, can be accurately placed to measure the range of motion. Okay, so like let's go back here for wrist flexion here. You see the hand is off the end of the table here, so that's so you can actually position the goniometer where it needs to go, okay, so that you're not running into the table. So I want you guys to know too that like I said, there are different positions to measure the same joint motion in. We're only going to be practicing one per joint for simplicity and again for reliability and validity. And it is your job though as a PTA to think through the patient's scenario and determine how the best position to test them in once you get into the clinic. Okay, so like I mentioned, the patient with spinal stenosis, you would know after you are a full-fledged PTA that lying prone is uncomfortable for a stenotic patient. So then you have thought through that scenario and you are going to always have the patient's best interest in mind. So then you would not position them in prone to measure hip extension. Okay. You also, as a PTA, always try to measure how the PT has previously tested the range of motion, okay? And so then you are going to want to replicate the position that was previously used. Again, though, you're documenting if that's different from the standard. So here's an example of I don't know if this is a PTA or a PT measuring ankle dorsiflexion. Now, the standardized way to measure ankle dorsiflexion is with the patient in supine or in long sitting, which is where they're both legs out extended in front of them. But it looks like for whatever reason this therapist is measuring this in prone. So this is a different position. It would be documented that way. Okay. So here's the procedure you're going to follow every single time you measure a joint. Okay, now this is listed in your handout. I also have a little example video of my coworker Tess being a patient for you guys a couple years ago, showing like what I will expect to see for a skills check. Okay, you're going to do a brief explanation of the procedure. You always demonstrate the motion. So this can be a quick, so say, hey, you know, Jane, I'm going to look at your shoulder range of motion today. That looks like this. And then I show her, I lift my own arm up into flexion, you know. And you can do that simultaneously with the uninvolved side, because you always then also want to assess how much available active range of motion is available in their uninvolved side, so you know what will be functional for that patient. Okay, so if their left shoulder, say that's their uninvolved side, can only flex to 140 degrees, and you're measuring the right shoulder at 100 degrees, now full shoulder flexion is 175 or 180 degrees, so you know that for that patient, you know, reaching 175 degrees may not be feasible because they only have 140 degrees on their uninvolved side. Okay, so you do a quick scan of the uninvolved side actively, and then you're just scanning also their involved side. You can do it simultaneously, like a general quick scan. Okay, so you check the active range of motion uninvolved side, you assess the active range of motion of the involved side. You don't have to measure that, you can just eyeball it. Okay, and then you assess their normal passive range of motion and the end feel of first the uninvolved side, so again you know what's normal for that patient, and then only then you go into your actual, oh no, first I forgot one, then you assess the passive range of motion and the end feel of the involved side. So you have done 1, 2, 3, 4, 5, 6 whole steps before you even place the goniometer on the patient. Okay, so a very common mistake that I see with the students is they just go right into measuring the joint. That is what you see clinicians doing, and so I can understand that. However, you must follow these 1, 2, 3, 4, 5, 6 steps before you even place a goniometer on the person so that you guys get an idea of what is normal for that patient, okay? And assessing the end feel also. Then you align the goniometer using your landmarks listed on your handouts. And then you're going to measure the involved side, okay? You measure first the involved side, and then you measure the uninvolved side if they're different, okay? So when you're doing your skills check, you're going to measure the uninvolved side first, and then you measure the involved side, okay? So if I can give you a word of advice, as you learned last quarter, your lab is going to be chock full of information, and you are going to want to go home and practice on as many people as you can, okay? You're going to practice, practice, practice. That will help you, and I would suggest as you're practicing to go through this whole procedure each time. Yes, it will feel tedious, but then yes, you will get to your skills check and you will know exactly what to do, and you will get full points because you are all amazing SPTAs, okay? So the other thing that's good to do on practicing is measuring different joints. You'll get different end feels. If you can find somebody with an injury, that'd be cool too. So practice, practice, practice. All right, gang, I look forward to looking over your assignments here and seeing you soon in lab.